Good morning, ladies and gentlemen. It's a real pleasure for me to be once again here in this lovely place. I'd like to thank the scientific organizing committee and particularly Ellie for the privilege to participate in the Leg Club Foundation activity as a patron also. My lecture for today, they gave me a very large topic, as you can see, managing patients with chronic wounds. So I'll do my best to drive you into what we think as a dermatologist. Of course, I'll try to give you some future perspectives and some insight to what we're doing at this time in our department. These are my disclosures. I work with many companies in research, and not only in wound management, but also in dermatology. And this is the beautiful city where I was born, studied, married, lovely tower. And the hospital is just right in here. We're moving all the facilities to a new area, hopefully into no more than 4 to 5 years. So, as I said, I'll give you my perspective as a dermatologist. There will be a particular aspect which I hope you will find more and more in the literature in the next few years. And I'd like to start with this first step-by-step orientation. We usually, managing patients with chronic wounds, we usually start with a clinical observation. And as a dermatologist, we are quite inside of what we call skin lesions in order to detect to reach the final diagnosis and to detect the pathogenesis of the problem. So starting from human, we're now going more and more into specific aspect, probably not all the time, but in that typical specific type of wounds where you don't reach your clinical diagnosis immediately. You have to go more in detail, like tissue biopsy, where the dermatology is taking a big role. But going more in detail, as usual in medicine, we will be offered more and more a more specific evaluation, and there are some papers already, interesting papers on gene evaluation, even in venous leg ulcer patient. And we're reaching at the end a specific type of treatment for those patients which we like to call hard to heal, with some pharmacological therapeutic approach, including protein, and I'll show you what we are using at this time in dermatology. Because of this step-by-step, there are plenty of ways of approaching our patients other than clinically, with a different level of diagnostics. On top, you have some immunohistochemistry to reach out more in detail cells. Then blood sample, not the regular one, but more sophisticated, or as I said, tissue biopsy with specific microdissection. But in our opinion, the future is in the last part of this slide, where you see the role of genomics and proteomics. And those two so-called omics orientation, way of doing medicine, will have a big impact on the diagnosis and particularly management of every single disease in the near future. This will bring us to talk more and more at pharmacodiagnostics, which means that we're going to test our patient for a so-called tailor-made drug treatment. That would be fantastic to have a specific treatment for each single patient, not to waste any time moving from one treatment to another, like we see quite often in our practice. And talking about diagnostics and going back to the real practice, this is a passion for us in dermatology, but since many years now, we were moving all those diagnostics from general skin diseases to wound management. And as you can see, wound assessment is an essential part of managing patients with chronic wounds, as to step-by-step follow several aspects like simplicity, to be accessible, non-invasive because we're dealing with wounds, reliable and valid, but particularly reproducible. And I can tell you it's becoming more and more cost-effective in terms of availability. And this is a book we published together with two other professors a few years ago, still available on Springer, where you can find all the detailed aspects on assessment. But we also publish a new version of the famous time concept, as you can see here, with Professor Greg Schultz. And this is the new timetable, which we were able to modify according to the assessment tools. And as you can see, in between the two columns in blue, written, they've been modified according to time concept in relation to diagnostic step by step. And you can find the effect on wound bed preparation on those diagnostics and measurement. So diagnostic and assessment is becoming more and more practical. As you can see, those are devices coming from the computerization of our daily practice, non-touching our patient, ready to use, ready to deliver and send information to other centers. More devices coming from dermatology. This is a camera I like to show you, which is mainly in general cosmetic dermatology, where you have to deal with very fine surfacing reconstruction. But as you can see here, the three-dimensional reconstruction at that level is quite inside for two-dimensional and three-dimensional acquisition. And then you have all those software specifics in order to calculate your necessities. But because we, as I told you, we are passionate about diagnostics, I'll tell you what we've been doing and what we think is the future, particularly for you working on a district side. We like to give you an opportunity to think about how to manage your patients probably in 5 to 10 years. This was another paper we published regarding the role of biomedical sensors. This is a word which I found out quite recently. It was 5 to 6 years ago. Was introduced by our colleagues from the Department of Chemistry and Engineering. And so we started thinking about monitoring our patient with very tiny sensors to be placed into regular dressings, as I'll show you. And there was a project which reached the end last March, a 4 years project funded by the European Union, the top level of funding for us in Europe. The acronym SWAN Eye Care means Smart Wearable and Autonomous Negative Pressure Device for Wound Monitoring and Therapy. So what we were trying to do, and we had a final positive confirmation from the officers. They are very strict in releasing approval. So we've been able to develop a system focusing on 3 sensors. We started with with something like more than 15 sensors early on this project, and we reached the end with 3 sensors, which were pH, surface on wound bed, temperature on wound bed, and MMPs, matrix metalloproteinases measurement. Those sensors were embedded into a negative pressure device which we've been able to develop, and a tele-monitoring, as you can see in this cartoon in here, where the patient is staying home and the sensors are working, and families or nurses receive an alarm, and they reach the patient immediately and decide if the patient has to go to the center of excellence, to the hospital or not. So we tested and validated on a trial on diabetic foot ulcer and venous leg ulcer. And this is a slide showing what kind of devices, what kind of sensors we've been using. This is a tubing where the exudate is moving from one side to the other side, and there is an a fiber able to detect several MMPs, and this is the combination of pH and temperature. You know how much are important those parameters in controlling bacterial diversity, as they say right now. And this is the negative pressure device which we've been able to deliver, and a volunteer showing the portability of the device. This is the negative pressure device, and then there is a small equipment transmitter able to transmit the pH, temperature, and MMPs parameters to this device, and then to alarm the center. So patient staying home, you gonna have a better way of treating your patient, and this is the expected impact, particularly on patients. So a continuous home monitoring of a number of wound parameters. It might be that in the future we're going to add more and more physical and chemical parameters. There might be a personalized treatment initiated by the physician or nurse remotely and adapted to the daily measurements. But particularly, we're looking for a faster wound healing because of early identification and treatment of the real problems. The early identification of wound deterioration will lead to a reduced morbidity and amputation rates in diabetic foot ulcer. As you know, that's a specific urgent topic. The patient will continue the daily activities and will have a better quality of life, better mobility. The device is really, that's a first prototype. Can you imagine how much can we miniaturize that type of prototype? That there would be expected impact also on the society and healthcare, as shown in here. So principally a reduced healthcare costs because of reduced need for hospitalization. You hospitalize your patient as needed, not because of uncertain diagnosis or anxiety from your patients. So reduce also burden for the patient's relatives because of faster wound healing and remote monitoring. Reduce social cost and improve productivity because the patient is returning to work earlier. And we really think that would be an increased access to best practice wound care for patients living very, very far away in remote geographical locations. And daily nursing visits will be reduced because of this we don't like to call telemedicine because we are used in dermatology to telemedicine. You take a picture, you send a picture, skin is visible, and that's really easy. This is something more because of biomedical sensors. So Reduced daily nursing visit will allow more new patients to be included in the scenario. Going back to my initial slide, I like to modify and offering you a new insight from human to cell to gene and probably to sensors in the not too distant future. But going back to real practice, this is a famous slide showing the increase of products available from the very traditional one to the moist wound healing concept. You have outside in the exhibit very brand new technologies. So we increasing more and more, always following step by step in managing chronic wound patients, several essential criteria like moist wound ambient, bacterial balance, physiological blockers with some active topical treatment, and always the value of debridement. So I'll touch on those four aspects on few patients which we think are the very top and critical aspect which we've been able to treat in the last few years. And this is a pyramid showing step by step the level of technology you're reaching in the future, from new modern dressings to negative pressure, very famous. I'll touch on biologics, which is a new pharmaceutical way of treating potentially also patients with hard to heal chronic wounds. Then the role of tissue engineering, and at the end, potentiality also for use of stem cells. Several directions in topical treatment. We think that mainly because of your specialty. Tissue viability or dermatologist, general surgeon, you know that doctors are quite different in approaching patients with chronic wounds in accordance with their specialty. So here you have a variety of topical treatment, and I'll start from a patient which you are familiar with, a lady more than something like 70, 76, 75 years old, in bed with several comorbidities, a huge list of systemic treatment. We've been asked to consult this patient because of this lesion on the sacral area, and that was identified as a stage 3 pressure ulcer with some kind of what we were calling critical colonization, which is not anymore the terminology. There is a big debate about terminology in wound management. So let's say superficial infection, we like to distinguish in dermatology superficial from deep infection, several aspects, what to do, patient immobile, not able to respond to aggressive treatment, but because of technology and antimicrobials, as you can see here, 3 weeks, fabulous restoring of the wound bed with an antimicrobial. Another very critically healed patient, a poor lady, over 80 years old, with this ischemic type of wound bed, with the tendon exposed, not able to receive revascularization. So difficult challenge, very difficult. Cutting the tendons, that was the intention of several surgeons, plastic surgeons, or preserving. That was a challenging for us. The blood flow was not that good. As you can see, this is a mainly arterial component. So we took the opportunity to use active dressing, and the decision came into collagen, which is a good product where you want to try to restart and promote the wound bed. And that was really a miracle, I can say. This is a baseline, and this is a very thin granulation tissue we've been able to restore twice a week with the application of of a collagen sponge. I can say this is a once in a life probably, but at this time, as you can see, if you look at the edges, there is a chance to cover with a tissue engineering, cadaver skin, any extracellular matrix product. I can say that was really a spectacular case in our hands. Negative pressure is quite there. Is a concept, fabulous concept, becoming more and more portable. I'll show you a patient. You probably have seen that type of patients every day. There was 72 years old with grade 4 application of negative pressure after more than a month. Reaching this level, we at that time, that was more than 10 years ago, we been able to stop and continue with the regular dressings, and now we close the circle with ultra portable negative pressure, reaching the final closure. But this before and after gives you the potentiality of negative pressure, which is in our hands a good start. But continuing to managing patients, I'll give you our insight with biological treatment. What are biologic therapies? They mainly produce in living organism, which is quite good, and derive from mainly recombinant DNA technology from blood cells, typically made by large molecules, and most of the time administered by injection. There is only one drug IV injected. All the others are subcutaneously, and the patient is doing the treatment himself or herself. So several molecules already approved, particularly for inflammatory skin diseases, as you can see here on your left-hand side. All those problems may have some wound, either acute or chronic complication. Very rare, very aggressive. The treatment is there. And this is a cartoon showing the IV monoclonal antibody called infliximab, which is mainly targeting TNF-alpha, which is tumor necrosis factor alpha. Infliximab is a chimeric monoclonal antibody with a human part and a murine part binding TNF-alpha. TNF-alpha has been shown to be highly represented in venous leg ulcer exudate, and it might be the cause of chronicity in those patients not responding to moist wound healing and bandaging. Another drug we are using for psoriasis is called etanercept, also a TNF-alpha inhibitors, and this is a fully human monoclonal antibody. So TNF-alpha is the target at this time for those patients with hard-to-heal chronic wounds, including leg ulcer, not responding to standard treatment. TNF-alpha, as you can see here, is a pro-inflammatory cytokine which induce interleukin IL-1, 6, and 8, increasing the inflammation in the wound bed, but also going to activate neutrophils and lymphocytes, is going to increase the expression of adhesion molecules. And it's particularly inside of aggressive type of wounds like pyoderma gangrenosum, where there are plenty of treatment, systemic treatment available, probably less to do on a topical side. We've been treating several patients with pyoderma a few years ago, and we published this paper by using infliximab as a treatment. Very careful screening of those patients because these are very potent immunosuppressants, so you're going to activate infection like flu problem or tuberculosis. You better be careful to select your patients, also because of the cost at this time. But I'll show you, this was a dorsum of the foot, a typically location for an arterial wound. The blood flow with tendon exposed, as you can see here. So typical picture of an arterial component, and we were looking at pulses, peripheral pulses. We were looking at the color Doppler. Everything was not that good, but not at the level of ischemia supposed to create this type of wound. So as soon as we don't correlate the tissue blood flow with the clinical aspect, we take a biopsy. And the biopsy is not the diagnosis for a PG, but it is what we call diagnosis of exclusion. We're going to exclude any other aspect. For instance, even a squamous cell carcinoma, it might be the case in a chronic wound bed. So the tissue specimen was showing the characteristic infiltrate of pyoderma gangrenosum. We decided to start an off-label treatment with infliximab, and there was a baseline given by infusion. You start at time 0, and then you inject after 1 week, 2 weeks, and then every 4 weeks. It takes an hour and a half before finishing the injection. As you can see, this is a 4 weeks already starting the granulation tissue, and this is a 5 weeks increasing the granulation tissue, reaching that level at 12 weeks, where we can stop the injection, avoid any complication, and continuing with the standard treatment. And this is another patient we were consulting in a cardiovascular unit. This is a lower leg where you can see on top left a very atypical type of necrotic tissue, a very annular type of black eschar, which was created by a scalpel, a sharp material. Doctor was trying to remove the callus, the callosity, and to activate the edge, and was creating what they call a pathergy. Pathergy is particularly inside of pyoderma gangrenosum in 30% of patients, and you're going to reactivate the inflammation in pyoderma. So soon as you reach the diagnosis of pyoderma gangrenosum, avoid any sharp material. You have to be very gentle, like hydrogel, hydrocolloid, enzymes. Treatment must be systemic, and as you can see here, injecting infliximab 4 weeks, 8 weeks, and week 16 we've been stopping the treatment and continuing with very good result with this patient. But just to give you an opportunity to understand how where are we in recognizing the difficulties in managing chronic wounds? This is a tissue biopsy of a venous leg ulcer. You have the epidermis in here, which is the edge of the wound bed, and you have the wound bed in here. And this is the regular staining with hematoxylin and eosin, where you see plenty of different cells listed on your right hand side. So is a very large description which is not producing any specific opportunity for us as a practitioner. But if you do a different staining with anti-TNF alpha, I've been talking about TNF alpha, and there is a staining specifically produced for TNF alpha. This is a paper where a group in Miami, dermatologists, famous wound healers, Dr. Kirsner, they were able to treat hard-to-heal venous leg ulcer with an anti-TNF alpha drug. And as you can see in here, same picture on your right inside, but stained with TNF alpha on your left inside. As you can see, this brown color is the TNF alpha staining of cells, which means that you have some opportunity to use a drug. At that time was off-label in Italy. Now we've been approved for pyoderma to use anti-TNF alpha inhibitors regularly. So probably in the future there will be more and more what we call pharmacodiagnostics, and you have to keep in mind in your practice always to alert pathological specimen, a tissue biopsy. As soon as you don't see any negative or positive evolution of your patients, alert dermatologist if possible, and there will be more and more treatment at the level. Moving to tissue engineering, which is a kind of puzzle, as you can see here, where there is a real multidisciplinary approach from molecular biology, cell biology, genomics, biochemistry, even robotics will come more and more in this field of managing chronic wounds. And tissue engineering, particularly in USA, where probably the rules for application of those products are very strict, but more open for patients. In Europe, in Italy, but I presume also in UK, we are not able to use all those products like amniotic membranes immediately available in USA. Hopefully in the future, as you can see, these are the three main level: autologous, allogenic, and xenogenic way of treating patients with tissue engineering. And these are different level from the very beginning story of tissue engineering. This is impregnated gauze containing cells, and this is the delivering and application of those cells. There was a hyaluronic acid membrane produced in Italy several years ago, a product with living skin equivalents and a tissue culture media to transport your cells. Today, you rely on a plastic bag which you bring from your shelf and back to the patient easily available and with strong biological effect. Mechanism of action of tissue engineering, mainly three level of action. First of all, replacement and substitution. You have to consider the taking of your product. The autologous is the gold standard, but also there is a pharmacological action. Plenty of biological activities in those xenogenic products. So the induction of wound healing process. And at the end, for very large area to be covered, the environmental and structural type of action, like a barrier to prevent fluid and heat loss, particularly in heavy burn patients. And the normal skin and bioengineered skin are quite there, as you can see here, quite similar. This is a famous cartoon a long time ago, but we're still relying at that level of comparison. And plenty of application on a chronic compartment, as you can see here, venous, arterial, diabetic foot, probably less in pressure ulcer because of the heavy type of work you have to manage on those wounds. Pyoderma gangrene also has been treated. On the other side, plenty of acute wounds like this one, which is approved in the United States, epidermolysis bullosa. Very poor children which are now receiving from the government this level of treatment with very good results and saving their lives. So at the end, I'm reaching the top of the pyramid where you see the stem cells, a famous topic, fascinating level of medicine and practice. Where are we in managing patients with chronic wounds? There was a paper published by my mentor, Professor Vincent Falanga, who's now in Boston, Harvard graduate. They were able to use bone marrow cells to be cultured in in the lab and then applied in hard-to-heal patients. This is the procedure they were showing on the paper. A patient at time 0 with needed some debridement, which was done surgically, then bone marrow aspiration and application, and as you can see, a very good results. And there was a patient chronically healed, hard to heal, with plenty of comorbidities. They've been able to show the stem cells into tissue biopsy specimen, as you can see here. Those are a sample of mesenchymal stem cells into the tissue specimen from that patient. So a real proof that the cells were there. And that was my final slide with a very interesting conclusion for the future of managing chronic wound patients. There will be new opportunities at different levels, particularly on diagnostics, which we think it would be more and more a must for us in the small percentage of hard-to-heal patients or where we don't see any progression regarding standard treatment. Prognosis and prevention is another opportunity. Pain and infection control, always a must for us. And trying to reduce recurrences, which is another big topic which we don't cover too much in our conferences, and a faster healing. But particularly, this is my real final slide, showing a big apparatus in a probably orthopedic procedure. Question is always wound care for our patient. It's going to be inpatient treatment or probably more and more outpatient. I hope I was able to give you some opportunities to think about the future and managing those patients. Once again, I thank you all for your attendance. I like to thank the speakers allowing me to be first and catching my flight back to Italy. It's always a pleasure to be with Helly and a fantastic group. I'll be able to take any question you may have. Thank you very much.